Welcome back for the last and the most interesting pro-con debate of the day. As the trans-catheter procedures are increasing rapidly in India, this particular pro and con is very much need of the hour. And to talk on this, we have got two experts and two from the one of the two institutes which do very high volumes of TAVIs. Dr. Ganapati is a senior cardiac anesthesiologist from Apollo Hospitals, Chennai. He is a very regular faculty of IACTA TEE meetings, and he will be talking on pro TEE in transcatheter aortic valve implantations. And we have got Dr. Navneet Mehta. He is one of the most senior faculties of IACTA. He is director and head of the department of Eternal Hospital, Jaipur. He does a lot of high volume TAVI center, and he will be talking against like TEE is not always necessary for doing TAVIs. Over to you, Dr. Ganapati, please. Thank you.
Thank you, sir. My screen is visible?
Yes.
I am audible?
Yes.
Yeah.
Please go ahead.
Very good afternoon, everybody. I'm going to talk on TEE is necessary for TAVI. Coming to evolution of anesthesia and echo imaging for TAVR. In the initial TAVR experience, general anesthesia, endotracheal intubation, and TEE guidance were used. With the subsequent more and more experience, cardiologists started using moderate sedation, no endotracheal intubation, and TTE guidance. TAVI is usually indicated in surgically unfit high-risk patients. By avoiding TEE, we are moving away from safety towards fast-tracking in so-called minimalist TAVI, unfortunately in high-risk patients. Let me explain. This is a TEE scores. TEE scores over TTE in TAVI. There is a comparison between intraprocedural TTE and TEE in the review article in Journal of Echocardiography 2019. In this image resolution, TTE has lower resolution and suboptimal images due to supine position of the patients. And TEE has higher resolution. In general, the image quality is consistently optimal. Invasiveness, TTE is non-invasive. Yes, TEE is little invasive. And regarding the PVR assessment, it is better in anterior PVR, the TTE. TEE is better in posterior PVR. Pericardial effusion, TTE is slow to detect. TEE is faster to detect. Aortic root injury, it is less accurate TTE, and TEE is more accurate. Coronary artery occlusion, difficult to detect in RWMAs in TTE. TEE, it is easier to detect and fast. Mitral valve regurgitation, reasonable accuracy with TTE, but TEE is definitely better in assessing mechanism and severity. Complications, no complications associated by doing TTE, but oral and teeth injury and rarely esophageal injury or stomach injury can happen with TEE. Type of anesthesia, conscious sedation for TTE and GA mostly for TEE, but rarely it can be used with monitor anesthesia care also. Access site, transfemoral TAVI is only possible with TTE, but all other things are possible with TE. And monitoring, this is most important. With TTE, it is always interrupted monitoring, interrupted imaging, as the sonographer has to be in the fluoroscopy field, and fluoroscopy has to be discontinued during the image acquisition. Continuous imaging, although rare with TE, TE has to be withdrawn if it interferes with fluoroscopy field. And regarding annulus sizing, CT is the gold standard. And TTE always underestimates the annulus size by 1.4 millimeter compared to TE. And 3D TE is better and comparable to CT in annulus size measurements. As you can see in this biplane views, it is wonderful to measure the annulus size. TE is advantageous over TTE in intraoperative guidance, as I already told you, valve deployment, like one can find out the septal bump, asymmetric calcification, narrow sinotubular junction, short sinuses, bad LV, bad RV, and presence or absence of pericardial effusion pre-procedurally and inform the interventionalist. And advantages of TE in wire position assessment is beautiful because of greater image resolution of TE. And we can guide the cardiologist to pass the wire into the LV, which is a difficult step in a narrow aortic valve. And as you can see in this confida wire or the stiff wires in the apex, they can position it with the help of TE. TE can do wonderful assessment whether it interferes with the mitral apparatus or not. And advantages of TE in ensuring proper prosthesis placement. It provides continuous real-time visualization of annulus, valve, LVOT, and balloon, prediction and immediate detection of AR, confirm coaxial alignment of delivery system and valve in relation to LVOT, and help ensure that the distal end of the sapien valve stent covers the tip of the native AV to avoid complications. Post-deployment, the advantages of many, to immediately identify the complications like valve instability, leaflet dysfunction, aortic regurgitation, mitral regurgitation or impingement on AML, LV dysfunction due to coronary osteal compromise, pericardial effusion due to perforation, aortic dissection, plaque disruption, peripheral vascular complications. If you can see these complications, they are life-threatening. Even if you can avoid, you can identify these complications 2 minutes earlier by TE than transthoracic echocardiography, we are saving a patient, we are saving a life. And TE assesses AR better in TAVI due to better image resolution. This is a clock phase assessment of paravalvular leak. So if the resolution is more, it is it's better in assessing. So TE monitoring helps in identifying early the complications related to position related deployment related complications. If it is too low deployment, it is a too high deployment, the complications are pretty serious. Valve embolism can happen to LV, severe central AR due to AV leaflet overhang, periprosthetic AR, or too high implantation valve can embolize into aorta. All those are very significant complications which can be identified early by TE, continuous monitoring. And TE predicts intraventricular conduction delay in TAVI. There is a paper recently, and short membranous septum length and deep valve implantation identified by TE are predictors of developing conduction abnormalities post-TAVR. TE assessment may be comparable to CT in this regard. And randomized controlled trials are in favor of TE for TAVI. RCTs are highly recommended for TE for intra-procedural guidance and shown lower rates of mortality, stroke, and complications. TE don't increase costs. If TE can help avoid complications, then it saves time and cost and reduces hospital stay. In Part 2 SAPIEN 3 registry study, in which 85% of patients underwent TAVR with general anesthesia and TE guidance, the median length of hospital stay was 3 days only. Less contrast use, less acute kidney injury with TE. Baker et al. Evaluated 100 patients undergoing transapical TAVR and concluded the use of TE is associated with the dramatic reduction in contrast media use. Less paravalvular leak in TE group. The France 2 registry study concluded that the higher incidence of post-procedural AR in the LA group may be explained by lower usage of TE guidance during TAVR and the LA. GA and TE reduces mortality. Brazilian registry study concluded that the use of TE to monitor procedure was found to be a protective factor against overall and late mortality. There is another 2 studies in the intermediate risk group. One had GA and TE and the other had the LA and TTE. You can see the 30-day all-cause mortality rate and cardiovascular mortality rate is significantly less in GA with TE group. And the ACC in 2012 recommended the TE as a mandatory tool in TAVR procedure. However, in 2017, ACC changed their statement as the TE was an alternative tool and quoted without TE, TAVR could be done safely, but we might lose some details. The point is, why should we lose any details in high-risk patients? So to conclude, TE is used as an intra-procedural monitoring tool, and the data support the use of TE to prevent complications and improve survival in TAVI. As the risk profile of TAVI patients decreases in intermediate and low risk patients, so does the risk of general anesthesia and TE. If TE can help prevent 1 death out of 100 TAVRs, it is worth to use it. Physicians performing TAVR need to continue to advocate TE for their patients and resist succumbing to the short-term economic pressures that in long run may increase healthcare costs and result in poor outcomes. Thank you.
Dr. Navneet Mehta, please.
So thank you. Yeah, good afternoon. Thank you so much. Am I audible?
Yeah.
Yes, sir.
Yeah. So I'm grateful to the organizing committee for giving me opportunity to share my experience. Since last 3 days, we have been discussing about the role of TE in different procedures, but I'm going to speak about a procedure where the role of TE has gradually declined. So transcatheter aortic valve implantation, or TAVI, is a non-surgical technique for the replacement of aortic valve in patients with a severe aortic stenosis. So this technique, after partner 1 trial in 2011, this technique was indicated for prohibitive and high-risk patients under general anesthesia with the use of the transesophageal echocardiography by the non-femoral or the open femoral technique. At that time, the echocardiography, especially the TE, was considered to be an important imaging tool. But later on, many other imaging modalities were introduced into the practice for the TAVI. We can use the transthoracic echocardiography for the diagnosis of the aortic stenosis and find out the feasibility for the TAVI. Indication for the TAVI has been later on expanded to the intermediate and low risk patients. So there was in 2021, now it's a demand for this procedure to be less invasive with faster recovery, minimal complications, and similar clinical outcome. But this is not possible with the use of transesophageal echocardiography because it requires general anesthesia and intubation. So newer approach is the minimalistic approach became popular, and we are using our center and successfully deploying the transcatheter heart valve in severe aortic stenosis patients. This minimalistic approach, it's a TAVI performed with a total percutaneous transfemoral approach under conscious sedation without the use of transesophageal echocardiography. Advantage of this technique: less invasive, improved recovery, early discharge from the hospital, and without compromising the clinical outcome of the patient. It has been shown in the STS-DVT registry also, there is a gradual decrease in the use of the general anesthesia and more use of the conscious sedations for the TAVI patients. With the shift from the general anesthesia to conscious sedation, there was also the transition from the use of the transesophageal echocardiography to transthoracic echocardiography during TAVI procedure. With increase in operator experience and the better pre-procedural planning, the complications which were occurring because of TAVI are now gradually on decline. You can see in the slide, in the different randomized controlled trials from 2011 to 2019, there is a decrease in the all-cause mortality, paravalvular leak, stroke rate, and the pacemaker implantation rate. Many imaging modalities are available for the pre-procedure planning, like transthoracic echo, transesophageal echo, fluoroscopy, CT scan. And we know that transesophageal echocardiography underestimates the aortic annular size, which can lead to the incidence of the paravalvular leak or the embolization of the valve. So it's important for the pre-procedure planning for the assessment of the aortic valve complex, which is a complex structure for the annular sizing, aortic valve calcification, distance between the aortic valve and coronary ostia, and peripheral vascular anatomy, to find out the appropriate procedural access and the size and type of the TAVI valve. So that CT scan has become a gold standard in comparison to the transesophageal echocardiography for the evaluation of the aortic valve complex and the selections and size and type of the transcatheter heart valve. It has been shown in various studies that CT scan is better than TE. New CT parameters like the area derived diameter and perimeter based diameter, they are now commonly used for the assessment of the aortic valve and the sizing of the aortic for the TAVI valve. And it has been shown in the various studies also, there is a decreased incidence of the paravalvular leak if we use the CT based diameter in comparison to the echo based diameter. In this study also, there is a decreased incidence of the paravalvular leaks if we use the CT based diameter in comparison to the TE based diameter. Now, after the pre-procedural planning, now come to the deployment of the TAVI valve. T is not required these days for the deployment of the TAVI valve because these days the cardiologists, they are using the fluoroscopy and the cine angiography, and they have the advantage of the assessment of any complications causing the acute hemodynamic instability also. In this video, you can see the deployment of the TAVI valve under fluoroscopy, the femoral puncture, then crossing of the aortic valve, balloon dilatation, and finally the deployment of the valve. Fluoroscopy and cine angiography can also use to find out the acute hemodynamic instability causing because of the complication, like in first video, the occlusion of the left main coronary artery. In second video, there is a paravalvular leak. And in third video, there is a migration of the TAVI valve into the ascending aorta. And sometimes the unusual complications like the under-expansion of the TAVI valves because of the presence of the calcification, as you can see in the upper row, or in the lower row, it's because of the previous prosthetic heart valve, and these patients, they needed the post-dilatation for reduction of the paravalvular leaks. So whether to use the TE-guided TAVI or the transthoracic guided TAVI, the center of the debate is the paravalvular leak, because we know that paravalvular leak is a predictor for the early and the late mortality, as it has been shown in the partner 2 trial also. So it's important for the operator to understand the mechanism and the predictors for the paravalvular leaks. It can occur because of the undersizing of the valve or the under expansion because of the calcification or improper depth of the implanted prosthesis. Various imaging modalities are available for detection of the paravalvular leak after TAVI procedure, but echocardiography has got certain disadvantages because limitations, acoustic shadowing in the far field, or most of the time the PVL jets, they are multiple in number, irregular shapes, and in different direction. It's a challenge for the echocardiographer to estimate the paravalvular leak after the TAVI procedure. So what do we have the other options? We can use the hemodynamic parameters or the cine aortography. These are commonly used these days. The hemodynamic parameters like the AR index or the CHI score, we are commonly used these days. So with the use of the CT scan in the pre-procedural planning, availability of the newer generation of the heart valve, which they have the extra outer skirt, and increase in the operator experience, there is a decrease in incidence of the paravalvular leaks. You can see in this slide, in the 2019, the partner 3 trial, which was published for the low-risk patient, the incidence of the moderate to severe paravalvular leak was less than 1%. So with the decrease in the incidence of the paravalvular leak, there is a less dependence on the transesophageal echocardiography for TAVI procedure. And it can be the detection of the paravalvular leak and other complications can be complemented with the use of the transthoracic echocardiography. We can use the parastatal short axis and the long axis view along with the apical 3-chamber and 5-chamber view for the detection of the paravalvular leaks. And also the cine angiography are commonly used these days. So this is the largest meta-analysis, which is comparing the use of the transthoracic echo and the transesophageal echo for TAVI, and it has been shown that there was no difference in the incidence of the paravalvular leaks. So that I can firmly share that with my experience that as of 2021, TE is not necessary for TAVI because of the now we are a minimalistic approach is commonly used. PVL incidence is decreasing. CT scan is a gold standard for the pre-procedural planning. Availability of the third and fourth generation heart valve and increase in the operator experience. Thank you.
Thank you. Any comments from Dr. Ganapathy or any?
Yes, sir. Yeah, in minimalist approach, we follow that only, sir. But we should have a team meeting, the heart team meeting before any TAVI procedures, before planning, depending upon the technical difficulties and expected complications, and whether to go ahead with the GA or TE. So that should be decided beforehand. Yes, obviously, straightforward cases, we also do a lot of minimalist approaches. But TE is a wonderful tool to identify as an intra-procedural monitoring tool. So suddenly some patient aortic perforation happens. TE definitely gets, obviously the result are not going to take same. The complications are, we can get hold of the reason for hemodynamic instability immediately. So that is my humble opinion.
So, Dr. Mehta, is there, in your vast experience, is there any changeover policy? Like if you are going ahead with a minimalistic approach and suddenly there is some patient-related complication or procedure-related complication, do you switch over to general anesthesia and then you do transesophageal echocardiography? Any experience like that?
No, like almost I have completed more than 150 patients, and maybe couple of times we have to switch over to, like, we have to intubate the patient because of that's a complication that we have detected by the fluoroscopy or the transthoracic echocardiography. It's like that sometimes it's a migration of the wall like that. So obviously that patient became the hemodynamic unstable and you have to intubate the patient. But as of now, we never use the transesophageal echocardiography. I think we were able to manage with the transthoracic and with the complemented by this fluoroscopy and cine angiography. And actually the cardiologists, the operator, they are actually dependent upon the fluoroscopy and cine angiography. They rely more on that, even rather than the transthoracic echo. Obviously, transthoracic echo, we can see that pericardial effusion, tamponade, like that.
I want to comment on this. We have done patients even not able to lie down on emergency basis. Also, patients for TAVIs. Those type of patients we have to intubate electively. Those type of patients even cardiologists want, especially ejection fraction low patients, 30% EF, 25% EF patients. If they don't tolerate the complications. So the interventional cardiologist has to also, we should ask them before going ahead with GFT or the minimalist approach. So depending upon that, we use that, and we also had to change 4-5 times to emergency intubate and all to convert conscious sedation into a GA. So those type of things, we will always have a TE. If at all we institute GA, definitely we'll have TE. Those type of patients are obviously the complicated patients. So TE will really help hemodynamic management to confirm what is going wrong, all those things. Yeah.
Okay, and a quick question to both of the speakers.
Dr. Deepak Bode,
yes, sir.
Kindly make
question.
a final comment and conclude.
Dr. Raju, sir, you can make the last comment. Yes.
Dr. Gupta?
Yeah, that was a wonderful pro-con session by all the 4 speakers, Dr. Binati, Dr. Saibal, Dr. Ganapathy, and Dr. Navneet. I think for the lack of time, I think we'll have to conclude. The discussion can go on and on. I think TE definitely has a role, and the transthoracic has slowly taken over. And in the critical care, both TE and PAC, they have important contributions to make. Thank you. Thank you again.
Thank
All
you.
right.
Thank you. Thank you.
Thank you, Dr. Raju, the moderators and the speakers for such an extraordinarily wonderful presentations. That was a tough competition indeed. Well, we'll be starting our next session very shortly. Meanwhile, kindly watch the promotional videos. Stay in touch. Thank you.